We're now recording. Today we'll be going over chapter 27, which is going to be the bleeding lecture. It's going to be a pretty short lecture. All bleeding does stop, so at some point or another, usually they say between 7 and 10 minutes, but some of us have seen longer. All right, so your national EMS education standards and competencies. All right. So introduction to bleeding. Bleeding can be one of the most time-sensitive conditions you'll face as an advanced AEMT. Right, so bleeding can be external and obvious, or it can be internal or hidden. No way, right? No way. Either way, the bleeding is going to be potentially dangerous, and it can cause weakness, shock, and death. Okay. Who remembers the triangle from last lecture, from the lecture on Monday? Does anybody remember it? And can tell me what the three sides represented? Anybody? That's right. So acidosis is one of them. Lactic acidosis is one of them. What else we got? Hypovolemia is another one. So you got coagulopathy. So it's really coagulopathy is what it is. So you got coagulopathy, and you got metabolic acidosis, and you got one more. One more. I just realized my face is all up in the camera. So the last one is hypothermia, right? It's all the stuff. Treat for shock. Okay. So, nope. You got, so it's hypothermia, coagulopathy, and metabolic acidosis. Okay. So you got your coagulopathy. It's going to lead to lactic acid, which is going to lead to your metabolic acidosis, which is going to cause, which also will call, as it follows through, will be decreased myocardial performance. Because of that, you get into your hypothermia from there because it's all, you're all draining out and everything, right? And then once you get to that point, it's going to halt the coagulation, the coagulation cascade. And then it just goes back around again. Is that a triangle? Something like that. All right. clicker's not working. There it goes. So perfusion, we've talked about it many a time. So perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. Okay. Blood enters an organ or a tissue first through the arteries and then the arterioles and finally the capillary beds, right? While passing through the capillaries, the blood delivers nutrients and oxygen to the surrounding cells and picks up waste that they have generated. Oxygen and carbon dioxide exchange oxygen and carbon dioxide exchange is going to take place in the lungs. The autonomic nervous system monitors the body's needs and adjusts the blood flow as it's required. All right. So in shock or hypoperfusion, the system fails to provide sufficient circulation for every body part to perform its function. So emergency medical care is designed to support the heart or the cardiovascular system, the brain and spinal cord, central nervous system, the lungs, respiratory system, and the kidneys and the renal system, right? All right, so physiology and perfusion, the cardiac cycle. repetitive pumping process that begins with the onset of cardiac muscle contraction and ends with the beginning of the next contraction is going to be your cardiac cycle. Preload is the amount of blood returned to the heart to be pumped out. Is the amount of blood returned to the heart to be pumped out. Afterload is the pressure in the aorta or the peripheral vascular resistance, PVR, against which the left ventricle must pump blood. Okay? The left ventricle must pump blood. So the cardiac cycle is connected to bleeding and shock through its relationship to blood pressure, right? So blood pressure is going to equal cardiac output times peripheral vascular resistance. See if I can do this. I can't draw on this thing, man. It's so, I can't draw on it. I was going to try and draw on it. I can't do it. Not effectively, anyway. I need my tablet in order to draw on it. I was going to draw it. So blood pressure equals cardiac output, or CO, times peripheral vascular resistance, PVR. So you'll see blood pressure equals CO times PVR. Okay. Your mean arterial pressure is going to be your MAP. Okay. So to figure out your MAP is going to equal diastolic blood pressure times 1/3 pulse pressure. Pulse pressure is calculated by subtracting the diastolic blood pressure, or the DBP, diastolic blood pressure, from the systolic blood pressure, or the SBP. And cardiac output is the amount of blood pumped through the circulatory system in 1 minute. The amount of blood pumped through the circulatory system in 1 minute, 60 seconds. The delivery of oxygen to the tissues is dependent on an adequate heart rate, hemoglobin levels, and arterial oxygen saturation. All right. So pathophys. A hemorrhage is a discharge of blood from the blood vessels. It also simply means bleeding. That's a hemorrhage, bleeding. Insanguination would be a lot of bleeding. So bleeding can range from a nicked capillary to, like when you shave, to a severely sputtering artery, like when you shave in very much so incorrectly, and to a ruptured spleen. And that's whenever you're shaving and somebody comes in and hits you with a baseball bat in the abdominal area or what have you. External bleeding can often be controlled by using direct, even pressure, okay, either with your hand or a palm or what have you. You may need to use things like tourniquets or splints or hemostatic dressings, pressure bandages, things like that to get the bleeding to stop as well. But direct, even pressure. And if it don't stop at that point, it's time to move on. And do not hesitate to use a tourniquet if you need it. Okay. Used to be, when I first became an EMT, they used to teach you that tourniquets were bad, that you used a tourniquet as a last resort. That is no longer true. Now, if you need it right then and you need to stop the bleeding, then use the tourniquet. If you can't, if you see that the bleeding is that severe, use the tourniquet. Get on it. Use it quickly. I got a pretty good demonstration that I use in my TCCC classes about, you know, how much blood is considered a lot of blood. Basically, all I do is I have a 5-gallon bucket full of blood, and I put out. I'll do it in a couple of settings. I'll put 500 cc's of blood on concrete, and then I'll put 500 cc's of blood in sandy ground, kind of give you an idea. And then I'll go around, I'll put 1,000 cc's, and then I'll put 1,000, cc's in another type of environment. And then I'll put 1,500 cc's, just to give you an idea of what is considered a lot of blood and what we're looking at. And in different environments, what does that blood look like? Okay. On concrete or on slick floor, it looks like a ton of blood. When you're sitting in a sandy area or in the grass, it doesn't look like that much blood. So then you have to use, in either resort, in either factor, you should be looking at your patient. All right, drawing your final conclusion or your primary conclusion from your patient. All right, external hemorrhaging. It's usually a result of the break of the skin. The extent or the severity is often a function of the type of wound and the types of blood vessels that have been injured. Okay. blood from an open vein is much darker and it flows steadily, right? Bleeding from damaged capillary vessels in dark red and oozes from a wound steadily but slowly. Okay, so bleeding from damaged capillary vessels is going to be dark red and it oozes from the wound. All right, and you can see it there in the finger stick. Oh, and then of course you have so these descriptions, they're not infallible either, even though they are fantastic. They're not infallible. Some injuries that you might expect to be accompanied by considerable external bleeding don't always have serious hemorrhaging. So who's ever watched the video of this hockey player here? This one right here. Has anybody ever seen that? So that hockey player was, of course, they were playing hockey, and one of the players came up, and he went down. He fell. When he fell, the hockey player that was down was sliding. He stuck his foot up, and when he stuck his foot up, it went under the neck protection. The blade did of his what do you call that? Not rollerblade, ice skate. The ice skate blade hit him right in the neck. And I mean, it sliced him pretty bad. It jugged him. And he immediately, he hit his knees, or he went to all fours, and blood just started pouring out. All right. So out of his neck. And they had a, I think there was a doctor or something like that that was in the crowd that came down, and he skated off the ice. And the doctor came down and actually had to reach up there and pinch that jugular vein. So he had to reach up there and pinch that closed to keep him from bleeding out, and hold that dressing up to it as well, and then take him to the hospital. And he ended up surviving. But it was spraying out. It was a terrible, terrible scene. One of the other better videos to watch when you talk about bleeding out, how quickly, I think it was in Iran, had an Iranian police officer that shot a criminal that was over there. And so, one of the arguments that always comes up is, police officers in shootings is, why don't they shoot him in the arm, or why don't they shoot him in the leg? Well, this police officer shot this guy in the leg, and within about 2 minutes, the guy was dead. He bled out right there on the sidewalk. So it goes to show you that, you're shooting them. You could be killing them either way. You don't know if you're just going to maim somebody. But it shot him. He shot him in the leg, and when he did, hit the femoral artery, and the guy bled out right there on the concrete before anybody could do anything about it. All right, internal hemorrhaging. So internal hemorrhaging as a result of trauma may appear in any portion of the body. Non-traumatic internal hemorrhage often occurs in cases of GI bleeding from the upper or lower GI tract, and ruptured ectopic pregnancies, ruptured aneurysms, and other conditions. So you're still gonna have those same effects as far as shock. You're gonna have those same effects. The cool, pale, diaphoretic skin. They're gonna look very pale, almost whitish, or yellowish, depending on what's going on, where they're hit at. And then also they're going to have those same vitals. When you start checking their vitals, if you're trying to check them, then you're going to have that. They're also going to need the same treatment. So they need fluids. They need whole blood is what they need. But in our aspect, they need fluids and TXA. But you know, I digress. So that's the kind of things that you're looking for that. Now, one of those in there that I see is ruptured aneurysms. That's gonna be a tough one. Okay. As far as bleeding, some of those get pretty bad, especially if it's right close to the heart or in the head, right? And then GI bleeds, you're going to see different things. If somebody in their vomitus, okay, in their vomitus, and then if they defecate, what colors are we looking for? A dark red or tarry, almost black looking blood, right? Lets us know where this may be from. All right, coffee grounds. Yep, coffee grounds, dark tarry blood, dark tarry, coffee ground defecation. That's some kind of things that we'll be looking at. And it's not dry like coffee, it's like wet coffee grounds. Something else too is you have bleedings like varices. Who has ever witnessed an esophageal varices? Anybody ever witnessed one of those? Ty, you ever witness a esophageal varices? I'm sure you have. So those come with your very sick patients, like your cancer patients or patients that have been ill for a while, throat cancer patients, things like that. It can happen. It can happen in other instances too, but these are what the most common: esophageal varices, bright red blood, okay, and alcoholism. Yep. So bright red blood coming up, and I'm talking about at a rate that is astounding. We have filled up BVMs, the bags on BVMs, because of esophageal varices. Like it starts spraying up into the BVM and fill it up. It's very, very nasty as far as it makes a mess. Very hard to stop too. You can't. All right, so mechanism of injuries for internal bleeding. A high energy MOI should increase your index of suspicion for the possibility of serious unseen injuries, okay? So your internal bleeding commonly occurs as a result of falls, blast injuries, which we talked about last class, automobile and motorcycle crashes, which we touched on in last class as well. So you got to look for signs of injury using what? What is that acronym that we use when we're looking for bleeding or we're looking for injuries on our trauma patients? Does anybody remember? DCAT BTLS. That's right, Mr. Wade. So DCAT BTLS. All right, good to go. So you're looking over the chest or the abdomen. You're including contusions, abrasions, lacerations, and other signs of injury or deformity as well. You're not too late. You're right on time. There's no lateness. Work as a team. In older patients, Dizziness, faintness, or weakness may be the first sign of non-traumatic internal bleeding in your older patients. All right, so some signs and symptoms of internal bleeding that you may see is pain, swelling in the area of the bleeding, bruising, bleeding into the chest may cause dyspnea, in addition to tachycardia and hypotension. Hematoma or a mass of blood in soft tissue beneath the skin. A hematoma is a fancy term for what? What's a hematoma a fancy term for? Bruise. There you go. So so you'll see bruising. And then you have hematemesis. Emesis. What is hema? Blood. And what is emesis? Right? Throwing up blood, puking blood. That's right. You have melena. What is melena? Or melena, whatever you want to, however you want to pronounce it. Somebody tell me what melena is and hematochezia. Hematochezia. So melena, like rectal bleeding. Yep, it's going to be dark feces. It's going to be partly digested blood is what that is. And if you have rectal bleeding as in hematochezia, it's going to be brighter blood. So it's the passage of the blood through the anus, through the anus or the rectal area. It's usually in the stool. All right. So some other stuff that you maybe experienced is pain. I'm just listening to my wife and son's conversation out there. It's crazy. So pain, tenderness, bruising, guarding. So guarding as in like in abdominal, swelling. So broken ribs, bruises over the lower part of the chest, or a rigid distended abdomen can be some signs and symptoms. The first sign of hypovolemic shock or hypoperfusion is generally a change in mental status, okay? Such as anxiety, restlessness, or combativeness. So some signs of hypoperfusion suggesting internal bleeding are going to be things like altered level of consciousness, tachycardia, weakness, fainting, or dizziness at rest. Extreme thirst will be thirsty. nausea and vomiting, cold, moist skin, shallow, rapid breathing, dull eyes, along with the eyes also, you'll see slightly dilated pupils that are slow to respond to light. Capillary refill is going to be more than 2 seconds in infants and children. They may have a weak, rapid, or what we call a thready, weak and rapid, thready pulse. And then if they have decreasing blood pressure, that's a very late sign. And it's no bueno. They have decreasing blood pressure. It's no good. So what's the importance of bleeding? All right. There's also an importance of not bleeding. If the typical adult loses more than 2 pints or 1 liter of blood, substantial changes in vital signs occur, okay? Increasing heart and respiratory rates and decreasing blood pressure is going to show up. The same effect is going to be seen with smaller amounts of blood loss in infants and children also, okay? So hemorrhagic shock. So hemorrhagic shock is a condition in which low blood volume results in inadequate perfusion and even death. Makes sense, right? So we need to consider bleeding to be serious if there's a significant MOI, especially when the MOI suggests that severe forces affected the abdomen, chest, or both. Poor general appearance of the patient. You start seeing signs and symptoms of shock. Substantial amount of blood loss, like we're talking about from visually seeing it. It's going to be severe. Rapid blood loss. That's not going to be good. And uncontrollable bleeding is not going to be good either. So the physiologic response to hemorrhaging. So on its own, bleeding tends to stop rather quickly in response to internal clotting mechanisms and exposure to air. Okay. When vessels are lacerated, the open ends of the vessel begin to narrow or vasoconstrict. All right, hemostasis. So in hemostasis, platelets aggregate at the injured site, plugging the hole and sealing the injured portions of the vessel. Okay. A number of medications, including anticoagulants, interfere with normal clotting. So make sure you know what those, or make sure that if you come upon those type of patients, that you're asking those questions. That's why that sample history is still important. So things like beta blockers, it can also prevent vasoconstriction as well. So you may have an issue. And then if you have a patient with hemophilia, which means you bleed a whole lot, right? Uncontrollably, don't have that clotting factor, you should be transporting immediately. All right. Now we talked about this and talked about this. It's very important. So a combination, so the trauma triad of death, hypothermia, coagulopathy, and acidosis. It substantially increased mortality in trauma patients. Coagulopathy. It's the disruption of the body's ability to clot and can result in further hemorrhage, leading to increasing hypoperfusion. You got to identify the conditions of hypothermia, coagulopathy, and acidosis in the setting that you're going to be in trauma, and you got to intervene wherever you can. Okay. So whatever you need to do to stop that bleeding or to slow that bleeding or to get to stop that trauma triad of death, you got to head it off at the curve as well as you can. So hypothermia and trauma, in the trauma triad, it's going to refer to the body's inability to maintain normal operating temperature because blood helps with your body temperature. It helps with thermal regulation. No blood, no thermal regulation. So I'm not quite sure how helpful that EMT is if he had enough time to get dressed, because I know how usually they get dressed. He got dressed and everything, and then got down there and helped old boy out. Plus that, I can't really tell, but aren't you supposed to wear your gloves over your sleevelets? Or am I being nitpicky? So patient assessment, you're seeing size up. The assessment of the patient, as usual, you're going to go through this, use your standard precautions. Make sure you wear appropriate PPE. So at this type of scene, it's telling you to wear your gloves, mask, eye shield, and a gown. If you can put all that on pretty quickly. For testing purposes, that's what you're going to wear: gloves, mask, eye shield, and a gown. We just talked about how blood's going to look different on different surfaces. You want to attempt to determine the amount of external blood loss. The best way to attempt to determine the amount of external blood loss, if you can't see it very well or what have you, is the patient signs and symptoms. Okay. So determine the nature of the illness or the MOI. And then consider the need for additional resources, such as another ALS unit or a paramedic unit or more hands. Unfortunately, a traumatic cardiac arrest, you have like a 0.000000001 chance of coming back from or being able to resuscitate someone in traumatic arrest. So you have to do everything you can to head off all of those issues at the curve to prevent that from happening. So your primary survey, substantial bleeding, internal or external, is going to be an immediate life threat. Your primary survey of the patient is going to include a search for life-threatening bleeding. So make sure you do that. Be aware of obvious signs of injury and distress, such as facial grimace. Okay. So you're going to perform a rapid full body scan of the patient. You're going to follow the XABCDE mnemonic for trauma, assessing for and managing insanguinating hemorrhage. Insanguination means it's coming out. When life-threatening external bleeding is seen, you got to begin treatment for shock. Do not become sidetracked by applying dressings and bandages to a patient who has much more serious problems, okay? You got to determine the patient's level of consciousness using the AVPU scale. After addressing those life threats, the life-threatening bleeding, next you got to manage immediate threats to life involving the airway and breathing. Okay, so you're not just skipping over. You got the rest of your ABC there. So you got to be able to quickly assess that pulse, the rate and quality. So not so much rate as in 100, 200, but fast, slow, rapid, rapid, thready, things like that. That's what overall. And then the quality being, is it thready? Is it bounding? Things like that. Development of tachycardia and pallor. That's some things here. I'm sorry, I skipped something. Yep, I did. So you got to make sure that you check for that rate and that pulse rate and quality. And then you got to determine skin condition and color, and then the temperature of it as well. Okay. And also check for your cap refill times, less than 2 seconds, right? Any internal bleeding must be treated promptly. You got to go quick on that. You got to pay close attention to the tenderness and the development of the tachycardia. And when making a transport decision in cases of hemorrhaging, determine how fast the transport decision should be made, and where the patient should be taken for definitive care. All right. Do you need to get out of there fast, or do you have enough time to mitigate things? So take into consideration factors that if they need stitches, or whether the patient has tetanus shot in the past 10 years, if they can answer that, whether the patient or his or her companion is reliable and will follow up properly with that as well. And then find the availability of any regional trauma centers. So history taken. You're going to investigate the chief complaint and be alert for signs and symptoms of other injuries due to MOI or NOI. You're going to carefully assess the MOI in trauma patients. And with substantial trauma, assess the entire patient, looking for the source of the problem. Any pre-existing illnesses or other issues may be problems of yours as well. So you're going to gather the information on the patient's chief complaint using OPQRST, right? And obtain a sample history. All right, so secondary assessments. So a detailed, comprehensive examination of the patient is going to be used to uncover injuries or illnesses that may have been missed during the primary survey, right? And then you're going to record the vital signs, complete a focused assessment of pain, on a scale of 1 to 10, 10 being the worst pain you ever felt in your life. Where's it at? Does it move? Is it, all that good stuff. You're going to attach appropriate monitoring devices along with that. So assess your respiratory system constantly. Assess the airway for patency and determine the rate and quality of the respirations, not just 16 and 18. Look for distended neck veins or deviated trachea. That could be an indication of some other things, right? Check for paradoxical movements of the chest wall and bilateral breathing sounds. So make sure you're checking for that stuff too, in the chest injuries. Assess the cardiovascular system and especially the rate and quality of the pulses. You're also going to assess the neurologic system to formulate a baseline data to guide further decisions along the way. You got to check their neurologic condition. Also assess the musculoskeletal system. Obtain baseline vitals to observe the changes. You got to start your trending process or continue with your trending process. In geriatric patients, the pulse rate may not increase with early shock, okay? So try to determine the patient's normal baseline blood pressure and circulatory status as soon as you can. You can also use your monitoring devices to quantify oxygenation and circulatory status as well. So reassessment. You're going to reassess the patient, especially in areas that showed abnormal findings during the primary survey. You're also going to assess the effectiveness of any interventions, especially if you have tourniquets. Make sure you check and recheck them. Make sure they're still tight. Okay. Make sure the bleeding's still stopped. If it's not, then you may need to add a second one. So in all cases of severe bleeding, you're going to obtain the vital signs every 5 minutes. But you know that. So it is important to recognize and estimate and report the amount of blood loss. You can do that visually, but if you know how shock progresses, you'll probably get a better idea. So long as the patient doesn't have anything on board or ETOH or anything like that, you'll probably be able to get a better idea of what's going on by the signs and symptoms and vital signs of your patient to know how much blood may have been lost or most likely has been lost. And it's the same way with internal bleeding. Just go for the signs, symptoms, and vitals, right? So for your medical care for external hemorrhaging, can be managed with direct pressure combined with pressure dressings or splints. So pressure stops the blood flow and permits normal coagulation to occur, is what's supposed to happen. The use of a tourniquet is preferred for external bleeding in an extremity that cannot be controlled with direct pressure or pressure dressings. So it's preferred. So you're going to provide high flow oxygen and assist ventilations if it's needed. And then also make sure that you pay attention to cervical spine control and your trauma patients as well. Don't forget about that. So apply a bulky dressing to stabilize any object that's protruding out of a wound. You know, like we talked about eye wounds and things like that. But if it's sticking out, you want to stabilize it up with that dressing. Okay. Keep it secure because it starts moving around, it could cause more damage. So tourniquets. It's useful if a patient has severe hemorrhaging from an extremity injury below the axilla or groin, and when other methods of control are ineffective. Tell you what, let's take a 10-minute break. I'm gonna go gather up a couple of items, and then I'll be back, and we'll talk about some of this stuff. So let me stop this here. Well, the popo is on it. I say it almost sounded like, oh yeah, SpaceX launched. That's great. Where are they going? We took video with our son on the first launch, of course, on TV, but it's pretty significant. So we took a video of it and all that good stuff. 10 minutes. I'll go watch the launch, and I'll be back. All right, we're back. All right, is everybody back? We'll see if my kid gets back like he's supposed to. Told him to come in here for one part of this. Hey, I need you to be in short sleeves. Yep. Thanks. I know. Or if you have a tank top, that would be even better. Sorry for screaming. I guess it'll do. Why are you wearing such a big shirt?
I don't know.
All right. So we're talking about tourniquets, Ethan. And I'm gonna put a tourniquet on you. You having small arms and being a child. But we're gonna go over tourniquets first. So we talk about tourniquets. You know, you have all different kinds of tourniquets, right? Most of the time we see this type of tourniquet, right? These type of tourniquets. Okay. Your cat tourniquets. I don't have my teachable C bags, so my swats and all that. But we do have things like we have these type of tourniquets, our stretch tourniquets. Okay. You can see up close. You know that you see how thin these are. You know that it's tight whenever those rectangles turn into squares. Then you know it's tight enough. Okay. All right. And I'll get to that one in just a moment. Yep. All right. So first, we're going to talk about our tourniquets, our cat tourniquets, the most common tourniquet. All right. Almost punched you in the face. All right. So if we're talking about parts of a tourniquet, nomenclature of the tourniquet, what do we call this? Anybody? What do we call this, Ethan? All right. So We call this the buckle, the single routing buckle. All right. What do we call this? This portion here. Anybody know? Okay, that's going to be the stabilization plate. Okay. What is this called? Right here. Velcro thing. Close. Self-adhering band. Self-adhering band. But it is Velcro. Why do we call it self-adhering? Because it self-adheres, right? It's got both the hook and loop in one. You know, you have hook and loop. Or you got hook and loop. So this is the hook and loop all together. So it adheres to itself, okay? All right. Up next, self-adhering band. The other end of the self-adhering band, what do we call this?
The end of the band.
The end of the band's good enough. Red, it's the red tip, right? Red tip. All right, something that we saw in some of our operators and some of our police officers is that they would take this band and then they would try to rub it off on the concrete, rub that paint off on the concrete. Don't do it. Don't do that. Because if you look carefully, see those squares, those little squares? That's going to be the attachments or the melting points right there for your ribbon. It's also on the other side too. And if you scrape that off, then you weaken that material, and that ribbon, there's a ribbon inside of all of this. I don't know if I can see it. Nope. So there's a ribbon inside of all of this. Can you see it, Ethan? Kind of. Yep. Ethan can see it. That's all that matters. All right. So and that ribbon connects from here to your stabilization plate. So if you scrape that down or it becomes weak, it will not evenly distribute the tightening factor for this. Because once you tighten down, that's what you see here. That's that ribbon. And as you can see, as I start to pull on it, it tightens up. Okay. And then I can stretch it back out. Okay. That tightening band there, that's what that's for. Okay. All right. So continuing on with the nomenclature. Got your single routing buckle. We already said that. And then next you're going to have, stay here. You're almost done, but not. Next, what do we call this? Somebody's got to know this one. What do you call this?
A stick.
Close, Ethan. Close.
Stick on a buckle.
No, it's not a stick. That's close, Cole. No. That is the windlass rod. You may see this on a test. Just saying. No, where you going? Leave that dog alone. All right. What do we call this? This is your windlass retention strap. Windlass retention strap. Okay. And then what do we call this here? Your windlass clip. Windlass clip. Okay, that's what this is. All right. All right, so you have 19 seconds variably to put this on to save your life or somebody else's life. Okay, 19 seconds. A lot of times they come in different types of holsters, either it be a hard holster or something like this that goes on a vest, something of this nature. Okay. But a lot of times they come in this. Stay here. They come and they look like this, right? Wrapped up, nice and neat. What good is that doing you? That's doing you no good. If your tourniquet is still wrapped up like this inside of your pouch, okay, it is doing you no good because it's not set up. It's not set up and ready to go. It's not ready to fight like it needs to be. Okay, so you must get this out. You must get it ready to fight. Okay. We see this all the time. We hand these out to people, and then they put them in their pouches, and that's the last time that they will look at it. But you have got to use them. You got to train. You got to make sure that they work correctly. You got to set them up, set yourself up for success. Okay, so how do we set these up? How do we set this up? You're going to route it through here. Okay. Leave you a little bit of slack there, right? Up at the top when you do this. Ethan, get back here. I'm not done with you. And then from there, you'll fold all this up on itself, okay? And then when you get done, it's going to be nice and neat and clean. It'll look something like this whenever you're done. Nice and neat, ready to go. You got that little bit of stick out there, or this little bit of extra here. And what that's going to do, it's going to help you when you grab it. It's going to help you jerk that thing in place. All right, so we're not going to get too far into that. You guys can practice that on each other at some boot camp. All right, so we start looking at these tourniquets. So those tourniquets there that we have, that's for adults, right? And I'll show you. Ethan, come here. All right. Hold out your arm. Okay. Now put this on him, and I'm not going to tighten it all the way down. I'm not going to, you got to come in further. All right. All right. So you can see here that the stabilization platform right here, it's bigger than his arm is. So you're not going to get a real good area for it to tighten on. A lot of the ribbon's not going to be able to tighten down on that. You're going to have a lot of extra too. Okay. So you're not going to have a lot to tighten on that. It's not going to be effective. So for children. So a lot of times we give these out to schools. Okay. We give these bands out to schools for school teachers or what have you. You take this band, it's very long. All right, Ethan, hold out your arm. All right. And you put this on, and as you put it on, you're going to keep it tight. Get it right, get it tight. And if I would have been smart, I wouldn't have rolled it out. All right, and you're making those squares like we talked about. Keeping it tight, keeping it tight. And you'll do that all the way to the end, however much you need to. And then when you get done, when you get it all tucked in, then you'll take this end piece and you'll tuck it up underneath once you get it all wrapped up, and you'll tuck it underneath itself. Okay. And that's going to help it stay tight. All right. How's that feel? You don't know how to explain it, and you can't say it's tight?
Yes, it's tight.
It's tight? Okay. All right, buddy. And that is what we use a lot of times on kids. Okay. All right, you can go, Ethan. Love you. All right, so a lot of time, any questions about any of that? I know that was a quick and dirty. There are a lot of YouTube videos on it if you didn't get it. But some other things that you may see in your arsenal is this. Can anybody tell me what this is called? Israeli bandage. So this is now this is a large Israeli bandage. It's like an ab pad of Israeli bandage. It's another thing to use to stop bleeding. As you can see, it's even, I looped it on itself and it's even hard to get off. Okay. That's the securing. That's the securing piece there. But then you also have you've got the dressing, the pad, okay, which this is a large one. But you also have this pressure piece here. And the way that pressure piece works is once you get it on there, you see this little area, this little piece right here. Okay. When you're spinning it and you loop this, you loop your wrap, your bandage through this piece here. When you do it, when you're wrapping, then you wrap it up and you're going to pull on it. And when you pull on it, you're going to go this way and it's going to create that pressure on that wound that's below here. Okay. And then you wrap it, and it's going to create even more pressure. And that's what's going to help stop your bleeding or slow your hemorrhaging there. So Israeli bandage. Okay. So stretch, wrap, and tuck, SWAT T, stretch, wrap, and tuck. Okay. And the other one was the cat. All right. Any questions about any of that? Should have brought my TCCC video. There's a lot better videos attached to it. All right. We just saw some of those, right? There's one of your other tourniquets. The soft T. There's a ratcheting, got a ratchet to it. All right, this one here. So a tourniquet it's going to be typically released at the hospital. Let them do it. Most of the time they'll cut it right off. It's your job to make sure it stays tight while you're en route to the hospital. If you don't have a commercial tourniquet, you can apply a tourniquet using a triangle bandage and a stick or a rod. All right. You need to make sure that it's got a wide band though. All right. You're looking for somewhere around 2 inches wide of a band to be able to create that pressure through there. Whenever you're applying a tourniquet, you want to ensure the tourniquet is proximal to the zone of the injury, proximal to the heart, right? And as close to the groin or axilla as possible. High and tight. So you want to use the widest bandage possible, like we said. Never, you don't ever want to use a wire, a rope, or a belt, or any type of narrow material, because it's not going to work as well. Now, some of our belts that we have now are EMS belts, do work well for that, but like your standard small type belts, braided belts, stuff like that. Ties rhinestone belt, it doesn't really work as well. His bedazzled belt doesn't really work as well. You want to make sure that it's tightened securely, and then you're never gonna cover a tourniquet with a bandage. Okay, you're not gonna cover a tourniquet with a bandage. You also want to inform the hospital on your radio report to the ED that a tourniquet has been applied, and best time to do it is while you're en route, when you apply it. That way you can get a time on it. All right, so here's a get this here. All right, what kind of tourniquet do we call that right there? What kind of tourniquet is that? Anybody tell me? Well, it's not quite a pelvic binder. It may be able to operate as a pelvic binder, but it's a type of tourniquet. And we call them something. There you go. Junctional tourniquets. Junctional tourniquet for junctional injuries. So injuries, severe bleeding injuries that are too high for tourniquets. Okay, you may be able to use a junctional tourniquet. As you can see here, it does bind. It does bind, Hannah, like you're talking about. It does look like a pelvic binder, and it may operate like a pelvic binder. But what you see here, this is a movable little pressure pad, okay? And it works just like a blood pressure cuff does. You tighten down on it and you pump, and it's going to create a pressure area there. If you don't have things like that, what else could create a pressure area there? If you have a pelvic binder and then you have a blood pressure cuff and you shove it up underneath there, that could work. You have a pelvic binder, or you have ACE bandage, something like that. A sheet, you have anything like that, and then you put a bandage underneath it, a big bandage underneath it, or something like that, to create pressure, a rock underneath it, just something underneath it at that junction to create that pressure as you bind down on it. So I think that's the SAM. Yeah, that's the SAM junctional tourniquet. SAM junctional tourniquet. All right, up next, splints. So you can see there, air splints can control the bleeding associated with severe soft tissue injuries. It acts as a pressure dressing applied to the entire extremity rather than to a small local area. Rigid splints can help stabilize fractures, as well as reduce pain and prevent further damage to soft tissue injuries. So I've done made a mess of my bag. Oh, well, it's for training anyway. All right. SAM splint. I've got them I had them in all shapes and sizes. Okay. Make it into different, you can curl it up For the arm, you can make a stirrup out of it. For the leg or for the foot to go in, you can make a stirrup. You can make a stirrup out of it to put an arm inside of. Okay, get both sides there. All sorts of stuff you can do with that. For now, got a desk job for now. You might see me back out there again. You never know. So always, whenever you apply any type of tourniquet or anything that's going to cut off circulation or possibility of cut off circulation, you want to make sure that you constantly monitor circulation at the distal extremities. Okay, just monitor it out and make sure you keep note of it. All right, hemostatic agents. Hemostatic agents. So this one here is Celox. It's not used as widely as some of our others. So it works by causing enhanced clot formation. I know we don't use the powder anymore. We don't use the powder. It caused a mess and it was causing issues as it was. It's like scraping a brick out of there. The agent's going to adhere to the damaged tissue, and either it's going to it hydrates the blood or it undergoes a chemical reaction that stimulates the natural blood clotting cascade. So after application, hemostatic agents, they should be able to withstand a high pressure or flow of a bleeding wound. Okay, and it's not going to cause, or it's going to cause little or no damage to the surrounding tissues on it. So also it's got to be easy to remove from the wound. Now they got to be easier to remove. They were having to scrape it out and everything. And then also the powder, they didn't want it spreading into the rest of the system, like in small particles, creating clots on its own. So you may use a lot of this, like you see this Z-fold hemostatic gauze here, the Celox. So the reason why they make it Z-fold is because that's the way that you're supposed to put it into a junctional injury. You just take and you Z-fold it, boom, boom. As you're putting it in, you're stuffing it in all those areas, right? Trying to get it in there. So it works by absorbing the liquid from the blood and helping to concentrate the clotting factors. And it involves taking standard initial steps to control the bleeding, including direct pressure, tourniquets, and other applicable tools and techniques as well. So you want to make sure that when you're putting that in, you're going as far into that area as you can to stop that bleeding, going all the way to the source of the bleeding with it. And then you Z-fold it in there. Don't just open it up and shove that whole square or that whole round in there. Actually get in there and fold it. A lot of times they will come with this blue strip. Okay. And this blue strip is it's going to be a radiopaque strip. And that blue strip, what that does is that, so if you take them to the ER and they do an X-ray, they can see that strip in there, that line. And then they know that there's something stuffed into their body that they need to remove. All right. So pneumatic anti-shock garments, or PASGs, right? Old school stuff. Old school coming back to the new school. So an inflatable device that covers the leg and abdomen. All right. And what it does is it almost like wearing pants. Okay. They're rarely used. And so, just make sure you follow your protocol if you do have a pair. Has anybody ever used these before? They're expensive. but they're hard to clean. And a lot of times you would get to the ER, and what would the nurses or doctors do? They'd go right through it. They became very expensive. I've seen them starting to come back in some companies. So hemorrhaging from the nose, ears, and mouth. So several conditions can result in bleeding from the nose, ears, or mouth. That's going to be like your skull fractures, your facial injuries, including those caused by a direct blow to the nose. Sinusitis infections, nose drop use and abuse, dried or cracked nasal mucosa, high blood pressure, and then some coagulation disorders, digital trauma, digital meaning your finger was from nose picking, you're picking your nose and started it. All right, so one of the bleedings we call epistaxis or nosebleed. Epistaxis is a nosebleed. It's quite a common occurrence, and it can cause enough blood loss to send a patient into shock, believe it or not. The blood you may see may only be a small part of the total blood loss. Much of the blood, it might pass its way down the throat into the stomach as the patient swallows. Okay. And of course, if you swallow blood, it's not easy on the stomach. For a nosebleed from other conditions, you're going to apply a cold compress to the bridge of the nose while the patient leans forward. And then an alternative to that is to roll gauze and place it underneath the patient's upper lip. So take a roll of gauze, place it underneath the upper lip. So bleeding from the nose or the ears following a head injury, that may indicate a skull fracture. If you do suspect a skull fracture, loosely cover the bleeding site with a sterile gauze pad to collect blood and to help keep contaminants away from the site. All right, so internal hemorrhaging. So definitive care includes rapid transport to the ED, right? You can usually control the internal bleeding into the extremities quite well in the field simply by splinting the extremity. Treatment focuses on the treatment of shock, minimizing movement of the injured or bleeding part or the region, and then rapid transport. Ultrasonography may be used to locate bleeding in the ED. So you want to make sure that you hook that patient up, right? He's lost some blood, then you need to give him some fluids. So you're not going to give the patient anything by mouth, nothing by mouth. Okay. You're going to insert at least one 18 gauge catheter. And you're going to administer bolus of fluids, 250 milliliters of normal saline or lactated Ringer solution. All right. At least one, which means you can put more than one. I usually go with two IVs. And then you want to monitor the serial vital signs. Watch diligently for developing shock. Hey, so look at this. What do we call that right here? Anybody remember that? What is that from? Can anyone tell me? Halo test. Awesome, Leanne. That's a halo test. And what is this around it? What is this yellow clear fluid? CSF, cerebral spinal fluid. That's right. Ding, ding, ding. All right, so management of a hemorrhagic shock. You're going to focus on ensanguinating hemorrhage first, that XABC portion of your assessment, right? The primary portion, XABC. You're going to identify and try to stop any major bleeding, quickly evaluate the patient's hemodynamic status with a quick pulse check. All right, we're checking for the rate and quality, right? And then establish and maintain an open airway while maintaining manual stabilization if it's necessary. En route to the ED, you're going to insert at least one, preferably two, 18-gauge peripheral IV lines. And then you're going to obtain IV access at the scene only if transport of the patient is delayed. If it's delayed, then of course you're going to do it at the scene. Other than that, do it en route. Get comfortable with doing it in the truck on 28th Street. 28th Street is it used to be a much worse piece of road, but it's not as bad as it used to be. It used to be terrible. If you didn't have an IV by 28th Street, you were going to be in a bind. You probably weren't going to get one by the time you got to the hospital. You're going to monitor the level of consciousness, pulse, and the blood pressure as well through all that. All right. And that is all I have. That is all I have tonight. So any questions about any of bleeding? Any of the bleeding stuff that we talked about? All right. All right, so the code for tonight. The code for tonight is going to be 5478. 5478 is going to be your code. Be the code to unlock the test. Be the code to unlock your attendance little sheet, and the code to the world. Okay. 5478. 5478. All right. Like I said earlier, I'm extremely sorry for the inconvenience for the cancellation of the boot camp. We'll be holding it on the 9th and 10th of October. As of right now, it's going to be at the same place. It's going to be twice as many people there. Should be a little bit bigger area there. You lost Monday's code. Okay. I'll have to look it up. Check. 9th and 10th is a Saturday and Sunday. 9 is a Saturday, 10th is a Sunday. Yep, 9687 was Monday's code. Nine, 6, 8, 7. Oh, was it? Well, dadgummit, Ty. Hold on. What? Hold on. Stop. Let me I will look it up. I will look it up before anybody gets confused. Look this bad boy up. We're not gonna. All right, here we go. The '16th is today, right? What am I looking at here? Okay, so the 13th, I'm sorry, the 13th of September. 13th of September is 9687. 13th of September, 9687. 15th of September, today, is 5478. Today is 5478. We got it? No problem. Cole and Ty are trying to psych everybody out. That's right, 5478. Okay, does anybody have anything else before we go? Yeah, what's the code to the vault? What vault? I don't have a vault. All right. I'm going to go ahead and stop recording.